So my name is Ashley Firm. I am a pharmacist, and today we're going to be discussing updates to asthma guidelines and treatment options. As far as a disclosure, I have nothing to disclose concerning any possible financial or personal relationships with commercial entities or their competitors mentioned in this presentation. And let's start with some pre-assessment questions. So which medication below is available in both a dry powder inhaler and metered dose inhaler, allowing for more personalized patient medication selection? Is it tiotropium, fluticasone salmeterol combination, albuterol, or ipratropium? Next, which of the following SNOMED codes can be used when counseling a patient with asthma? Would that be an asthma medication review, medication administration education, monitoring adherence to medication regime, or all of them? And all of the codes are correct for the indication aligned with it, so there's no mismatch with the codes. And lastly, for our pre-assessment, what device is used for a patient with asthma to monitor their lung function as an outpatient? So jumping into our objectives, we're going to review the disease state of asthma, including treatment guidelines and medication device counseling, identify gaps in care for a patient with asthma, including immunizations, asthma action plans, and alterations in therapy, and we'll discuss necessary steps to complete asthma adherence education within a dispensing workflow specifically for a payer contract. So a bit of an asthma disease overview, and this is just going to be brief, but we know asthma is a disease that causes airway inflammation and constriction, which is characterized by variable and recurring symptoms. This is different than COPD, where we see progressive symptoms, so we can see patients really have varying degrees of asthma severity depending on what is happening in their environment. And that's because asthma can have many triggers, including allergens, exercise, cold, smoke, anxiety, viruses, medications, and many other stimuli. And this stimuli leads to acute inflammation, which can develop into chronic inflammation and airway remodeling over time. And unlike COPD, asthma is reversible with proper management, which is why the following slides we're going to discuss are so important, because we can help reverse that asthma disease. So first, a brief overview, a review of the medication classes. So first, we'll start with our short-acting beta agonists, or SABAs. We're pretty familiar with them. The mechanism of action binding to the beta-2 receptors, causing relaxation of bronchial smooth muscle, which leads to that bronchodilation and the purpose of the medications. So we typically think of these as our rescue inhalers. Adverse drug effects, we know those as nervousness, tremor, tachycardia, palpitations, maybe some cough depending on the type of powdered inhaler used or the type of inhaler device, hyperglycemia, and decrease in potassium. And specifically for our SABA, some important monitoring is days of use, as well as our peak flow readings, because SABA use is going to be one of the greatest indicators of control of asthma and whether therapy needs to be escalated. Next group we have here is our inhaled corticosteroids, or ICSs. They work by a variety of mechanisms, so increasing the number of beta-2 receptors, reducing mucus production, hypersecretion, and most importantly, inhibiting the inflammatory response. We know that with our steroids, we can see some common adverse drug effects of thrush, headache, throat irritation, and again, that can depend on inhaler technique. And then serious adverse drug effects, concerns of reduced bone density, and we'll see that play out in our guidelines when we see that our younger patients do not have the same preference for inhaled corticosteroids as our adult patients. And low-dose ICS provides most of the clinical benefit of ICS for most patients with asthma. So although on the next slide we're going to talk about daily doses of ICS and low, medium, and high steroid doses, most patients should receive benefit with low dose. However, ICS responsiveness varies between patients, so some patients may need medium dose if their asthma is uncontrolled despite good adherence and correct technique, and high-dose inhaled corticosteroids in combination with a LABA, a long-acting beta agonist, or separately, is needed by very few patients. So it's important before we are escalating our doses of ICS that we do an inhaler adherence check-in. And it's not just going to be about patients remembering to take their medications, but remembering to use them correctly, because most patients should not need more than a low-dose ICS. Its long-term use is associated with that increased risk of local and systemic side effects, which is another reason to have preference for low-dose ICS. And then our table or categorization of daily doses of ICS, I want to make sure that we note that this is not a table of equivalence. It is just a suggestion of daily doses for low, medium, and high dose treatment options. This does not imply any potency equivalence, so it's not to be used as an interchange table, but it is going to help you give a range when you're thinking about low, medium, and high dosing of what that might look like for different agents. As we can see, there are many different types of ICS inhalers. And then just take note of some of the special notes down the right-hand column, some lower age limits, and also some allergy concerns specifically to milk proteins. Patients should avoid our fluticasone inhalers and our mometasone with that allergy. So next we have our LABAs, our long-acting beta agonist. In asthma, we know we never ever use a LABA alone. We always use it in combination with an inhaled corticosteroid. And monotherapy with a LABA is just contraindicating our asthmatic patients due to that increased risk of death. And for anybody who's unfamiliar with the mechanism behind that warning, if LABAs are used as our primary means of controlling asthma disease, if a patient has an asthma attack or an asthma exacerbation, their SABA may not be able to provide relief because all of those beta receptors are desensitized or otherwise occupied by our long-acting beta agonists. So we always want to use a combination product such as an inhaled corticosteroid if we're adding on a LABA. Now talking about our combination products, I present several on the screen here. And I really just want to call a bit of attention to our formoterol budesonide combination. And this is because formoterol is a very unique LABA. Most LABAs, such as our salmeterol or vilanterol, has an onset of action of between 38 and 45 minutes. Formoterol has a very short onset of action and mimics more of a short-acting beta agonist as an onset of action, but has a long duration of action similar to our long-acting products. And so for that reason, we will talk later in this presentation about formoterol and budesonide being used as both maintenance and PRN therapy, and that helped to show less glucocorticoid use compared to our standard of therapy. It did not show significant reduction in hospitalization, which is why we don't see it as a widespread recommendation yet, but we are going to talk about some guidelines that recommend the use of formoterol budesonide as opposed to SABA alone for any shortness of breath or asthma exacerbations. So kind of tuck that information away. We'll talk more about it later in the presentation, but just calling out that really specific pharmacokinetic properties of formoterol. So next up, we have our long-acting antimuscarinic agents, or LAMAs. May also be known as our anticholinergic agents. They competitively and reversibly inhibit the action of acetylcholine at our type 3 muscarinic receptors in our bronchial smooth muscle, which in turn leads to bronchodilation. We have just one agent in this class that is specifically approved for asthma. There may be other medications that we may see used. In an asthmatic patient, they carry indications specifically for COPD. So we have just our one tiotropium, and specifically only at the 1.25 microgram per inhalation dose approved for asthma. Adverse drug effects, as we would expect from these types of medications, are primarily anticholinergic, so dry mouth, constipation, also some abnormal taste. And the last oral medication we're going to talk about is our leukotriene receptor antagonists, or LTRAs. They block our leukotriene receptors and prevents airway edema and smooth muscle contraction. We do see several contraindications, agent-specific, that I've listed for you. Adverse drug effects, mainly headache, and some boxed warning for aggressive behavior. And then I do just want to call out with the different agents some specific dosing requirements. So montelukast, as we know, is once a day dose in the evening. Silutin is approved as once a day, but only for children 12 and older. And zarfalucast is dosed twice a day, 1 to 2 hours after a meal. I know by large standards, montelukast is our primary agent, but just calling out some of those other specific notes in case you do see the other agents utilized. Lastly, I'm also going to talk briefly about our monoclonal antibodies, or our MABs. And they really have an expanding role in the management of asthma, specifically and especially eosinophilic asthma, which many of these products require minimum absolute neutrophil counts prior to initiation, just to make sure that we're using the products appropriately. They may be infusions or subcutaneous injections. And so with that, we can expect injection and infusion site reactions. But part of the reason for having specific thresholds for use is because many of these products also carry an adverse drug effect of anaphylaxis. So we want to make sure that we are being very mindful in our patient selection, that we are picking appropriate patients. And these also require our standard MAB precautions, so infection prevention, completion of immunizations prior to treatment initiation, etc., the things that we're used to counseling patients on before starting a MAB. So with these agents, we're going to break it down to three kind of broad categories. So our anti-IgE therapy, omalizumab or Xolair, and that one's been around quite the longest. Anti-IL-5 therapy, mepolizumab, reslizumab, and benralizumab, and their anti-IL-4 receptor alpha subunit therapy or dupilumab. We're not going to go into an extensive review of each of these. This information is constantly evolving, and because most of this presentation is going to be focused on what we can do with our individual patients, I'm going to spend more of the time talking about how we as pharmacists can help to counsel our patients for better asthma control. So speaking of better asthma control and counseling, we're going to talk a good bit here about the review of inhalers, because there are estimates of inhaler errors, including up to 90% of patients using pressurized metered dose inhalers. So in this image from Javier Trigo, just some examples, we see a metered dose inhaler on the left. Our bottom left, we have a turbohaler. We have an autohaler and an accuhaler, or what we'll think of as a dry powder inhaler. And the Pharmaceutical Journal reports an estimate, as I said, of 90% of patients using a metered dose inhaler, and 54% of patients using a dry powder inhaler are using their inhaler incorrectly. So before we can talk about escalating therapy, adding new medications, it's really important that we as pharmacists take a moment to do a little timeout and a little checkout to make sure that the patients understand how to use their inhaler. I say this many, many times to my students. Medications don't work if patients don't take them, but medications also don't work if patients don't take them correctly. So we are going to spend several minutes here walking through these inhaler types, making sure that we as pharmacists are comfortable in what that inhaler technique should look like and how we can step in and help these patients, even if they've been on the medications for a good amount of time. So starting with our three main types of inhalers, we have our metered dose inhalers. They're typically indicated with the words HFA somewhere in the name. Our dry powder inhalers, they may have discus, ellipta, or dash haler. And then our soft mist inhalers, and these are typically represented by the word Respimat in the inhaler name. So starting with our metered dose inhalers, they previously contained chlorofluorocarbons. They now contain hydrofluoroalkane. So that's where the HFA comes from if anybody happens to ask. It's important to note that a spacer device can be used with a metered dose inhaler to help improve technique and reduce the potential for adverse effects from the medication. And most of those adverse effects would come from improper inhaler technique. There's individual instructions based on the product for cleaning. So it's important that most of these inhalers are cleaned at some point, but individual products will dictate how that should be done. Priming is also product dependent. What's nice about the metered dose inhalers that is, aside from the occasional priming, there's no drug preparation needed. And we'll talk about why that is utilized in our dry powder inhalers, and that bullet point will make more sense. But one of the drawbacks is we see high pharyngeal deposition. And so how to use a metered dose inhaler. Shaking, remember that these are suspensions. Patients should breathe out and then breathe in slowly while depressing the inhaler and hold their breath for 10 seconds before breathing out. This does require a good amount of hand-breath coordination, challenging for patients, especially younger patients or patients that require assistance with the actuation of the dose. Part of this can be overcome with the addition of a spacer. So some important notes about spacers. Correct spacer size. Spacer sizes may need to change as the child grows. You can also add a mask of further aid coordination. And much as we all know, masks should cover our nose and our mouth. Patients should wait 1 minute in between doses, and they should breathe in 3 to 5 times for each dose. So adding a spacer can add a little bit of time to the total time needed for a dose delivery. Spacers should be washed at least weekly with soapy tap water. and we should replace the one-way valve when the valve dries out and starts to curl. So how a patient can use their spacers, they would still shake the medication, because again, these are suspensions. They would insert the inhaler into the rubber sealed end of the spacer. They would deploy the dose and then breathe in and out of the lungs 3 to 5 times for each dose. So what the spacer really aims to do is help to remove that coordination between the breath breathing and the dose actuation. So this is a little bit different than our dry powder inhalers where they are breath actuated. So we need to consider the patient's ability to generate adequate inspiratory force. These inhalers may be challenging for patients, especially when first starting their therapy, if they are having difficulty with their breathing and being able to create enough force to actually dispense the medication. It does, however, help to overcome hand-breath coordination challenges of our metered dose inhalers. And this is where we say the dose must be loaded. So most of these medications require a dose to be loaded into the inhaler that may be physically loaded, or it may be in some way deployed within the inhaler before the dose can be given. And we also see high pharyngeal deposits again. So how to use a DPI? Open the inhaler. We see that clicking is a way that we would deploy the inhaler, deploy the dose into the inhaler. Patients will breathe out, breathe in deeply through the inhaler, hold their breath for a count of 10, breathe out slowly, and close the inhaler. So we see it's a little bit easier because there's no coordination of the dose actuation and the breathing, but it does require that force. Our last kind of inhaler group we're going to talk about is our soft mist inhalers. They have higher fine particle fraction to improve the lung deposition and lessen the oropharyngeal deposits. And they require both hand-breath coordination and a positive inhalation force, but less of each compared to other inhalers. So kind of it takes a little bit from our MDIs and a little bit from our DPIs and merges them together. In here we have just the one type of soft mist inhaler right now, the Rescue inhaler. Instructions would be to open the cap, exhale, remove the mouthpiece, press the dose release button and inhaling deeply and slowly. Hold the breath and exhale slowly. So we see it doesn't really require specific coordination. It doesn't require excessive inhalation force. So it is a combination of our DPI and our MDI. One very important part about our Rescue inhalers is to make sure patients know to never ever remove the canister from the inhaler. It comes disassembled and requires the canister to be inserted into the inhaler before first use, but it should never then be disassembled. It doesn't require disassembly for cleaning or anything of the such, because once the canister is removed, it cannot be reinserted. And then lastly, to talk about nebulizers, I don't include them as one of the inhaler types because they are different, but I do just want to talk about them briefly. They're good to use in elderly and children due to really no need for technique, so it doesn't require any amount of inspiratory force. It doesn't require any coordination and has shown equal efficacy to meter dose inhalers. It is not always a portable device. Typically, they do require an electrical outlet. Some may be battery operated, but those are considerably more expensive, and it's more time consuming. Administration of a dose takes about 10 minutes. More expensive in that it does require machine purchase. The individual medications are typically cheaper. So to use a nebulizer, they'd place the medication into the medicine chamber, assemble it attaching the mask, the mouthpiece, depending on how they're going to use it, connect the tube with the compressor, turn on the compressor, and then inhale the medicine through the mask or the mouthpiece. Again, it takes about 10 minutes to administer that full dose. And then we would turn off the compression nebulizer and disassemble. So when looking to provide inhaler technique education, there are some SNOMED codes, which are procedure codes that are part of our e-care planning system that can help to document what you've done. So you can use medication administration education, medication administration education, guidance and counseling, or medical equipment or device education. These are just a few examples of codes you can use. There are many more out there, and I'll give you some SNOMED resources later in this presentation, but I would just consider these as some available options to best represent the work that you're doing when you're providing this inhaler technique. So your turn. So I want you to take a moment, think of an example of a patient inhaler technique education session that you found helpful to the patient. How did the encounter start? Was it patient or pharmacist initiated? And what was the follow-up afterwards? And I think it's always great to also talk to your patients who have been using these inhalers for some time and asking them for what some of their tips and tricks were when they first started. And that's also a good way to provide a little mini check-in to those patients to make sure that they're still using their inhalers correctly by asking them to give you some helpful advice for new patients. So now moving on to our asthma control guidelines, we have two main guidelines that we're going to use. The National Heart, Lung, and Blood Institute, or NIH. Most are more familiar with the NIH guidelines, but we also have the Global Initiative for Asthma, or GINA guidelines, and there are some important differences that I will point out that can affect patients' adherence or perception of adherence. But globally, our treatment goals remain very similar. We want to achieve and maintain control of symptoms, maintain normal activity levels, including exercise, maintain pulmonary function as close to normal levels as possible, prevent asthma exacerbations, avoid adverse effects from asthma medications, and ultimately prevent asthma mortality. So at a glance, here are the 2020 focus updates to the asthma management guidelines, and these would be our NIH guidelines. There were some updates in 2020, but the step therapy remains largely unchanged. So we see our step 1 is our PRN SABA therapy. Step 2, we add some maintenance therapy, and we progress up based on how patients are maintaining adherence. And there's some ways you can gauge adherence. We identified SABA use as one of the most common ones. So SABA use more than 2 days a week is typically an indication to step up. We're not going to talk extensively about how patients enter into the system because from the pharmacy perspective, it's more important about making sure that they are escalated if needed. And to note here that this is our guidelines for ages 12 and up. So we see step 2 uses daily low dose ICS. This is a little bit different than our ages 5 to 11. There are also specific guidelines for ages 0 to 4 that we will not cover extensively in this presentation. But if you compare the 5 to 11 to the 12 and older, we see that the 5 to 11 is more conservative on our ICS dosing and prefers more of our low dose formulations. This is a little bit different than our GINA guidelines. So the GINA major update, the full report is available for individual download. GINA's copywriting only allows for a single download for educational purposes. So I really just wanted to err on the side of caution and not include any of their specific figures, but I do include the direct link to see the download for yourself. Some major highlights that came out in GINA in 2019 was a recommendation against SABA only. So it wasn't even just that they had more of a preference for another agent, but they recommended against using only a SABA. And they found that, through several studies that just 3 SABA prescriptions per year is associated with a higher risk of ED visits. And regular use of a SABA is associated with beta receptor downregulation. So GINA's recommendations is the use of that low dose ICS formoterol for PRN use, or use of low dose ICS plus a SABA PRN. So they skip over that step 1 in our NIH of using a SABA only for as needed rescue therapy and want to see a formoterol PRN combination with ICS use. And so I really like to stress this part because I know as a pharmacist, I always had kind of, my guard up if I saw a medication for asthma that I believe to be a maintenance inhaler being utilized PRN. And I started to see this more often with our formoterol budesonide prescription. So I want to point out that this is where that recommendation is coming from and that we may start to see more of this formoterol budesonide PRN use and making sure that patients understand how their specific prescriptions to be used because it is still very much a maintenance medication as well. So point out this important GINA update. Now this is an asthma control test, so this is a great way to check in with our patients to make sure that they are at adequate asthma control. This is specifically the adult test for children 12 and older. And you can give this to the patient, either verbally give it to them, so maybe you're doing a phone consultation, or you can provide this for a patient to fill out themselves. And you can see that each of the boxes has a score associated with it. So if the score is 19 or less, control is not optimal. So if they have even one question that they are not having no symptoms, then we would consider their control to be less than optimal. First step, if we identify a patient 19 or less, is really to be reviewing adherence and inhaler technique. So it may not be that we need to change medication. We may not need to have a dose escalation. We may not need to add more medications and further adherence barriers. But first step is reviewing adherence and inhaler technique. And when I say reviewing adherence, I don't just mean checking in on the fill history, but really making sure that patients understand how to use the medication and are using it correctly. And then if no issues are identified there, consider an increase in step therapy. There's also a test specifically for our children 4 to 11. So questions 1 through 4 are administered to the child, and then 5, 6, and 7 is to the guardian. And this would use a scoring system of less than 27, would mean that there is room for improvement in management. Although the asthma control test itself does not indicate specific therapeutic adjustments, most of the symptoms that are tracked in the asthma control test are also used when assessing control and introduction to therapy. So we can see here, and this is the same graphic, I split it into 2 columns to make it a bit more readable. But our left-hand side is our NIH guidelines, and our right-hand side is our GINA. And we can see that based on what the symptoms are and how frequently they are experienced, that's where we would enter the therapy. So step 1, step 2, step 3, step 4 to 6. But you also can use this to decide if patients need to step up in therapy. So if they are having daytime symptoms more than 2 days a week, if they're having nocturnal awakenings 3 to 4 times a month, it may be time to step up their therapy and make that recommendation to the provider. And again, this leads to some potentially billable services or interventions. So some SNOMED codes to consider, assessment using the asthma control questionnaire. So if you deploy that questionnaire and have a score for it, you should be documenting as a SNOMED code. Asthma medication review. So let's say that an adult patient scores an 18 and you want to provide some medication education. There we go. Asthma education and education about respiratory disease. So maybe you talk to the patient and they just didn't really understand that they needed their maintenance inhaler year round, that they thought they only needed it maybe during the springtime because that's when they have allergies. So providing that education about the disorder and how we can best manage those medications year round. And again, these are just a few of our asthma-specific SNOMED codes. There are many others related to medication synchronization, general education, counseling, and recommendation to prescribers. For example, asking for an increase in a medication dose or a change to another product. I would encourage you to also become familiar with some of those SNOMED codes that you have the ability to also document for those. And just to provide some other potential patient encounter options, as I already identified, there are many other opportunities for documentation. So do not think that you can only document when a problem is discovered. It's just as critical to show the impact of pharmacists maintaining good asthma control through education and adherence monitoring. CPSN provides many resources on using SNOMED codes, so I suggest building your list of go-to codes that fit your patient encounters. But these are also some other opportunities where you can quote-unquote stack your SNOMED codes. So maybe you have a patient who is in your medication synchronization service and they have a medication synchronization appointment to review their asthma medication. So I show you the SNOMED code associated with that. With that, maybe you administer the asthma control test, and guess what? They score a 20. They don't have any issues to identify, but you still administer that test. So let's go ahead and add that code. And then you can provide some education, congratulating them on good adherence and proper inhaler technique and to keep up the good work. So there's a code for that. Maybe you have a patient with a new asthma medication and you offer them an immunization screening to go with their new diagnosis of asthma. And maybe through that screening, you discover they never got a flu shot this year. So you can have a SNOMED code for new asthma medication, immunization screening, and offering their influenza vaccine. To build on that, we'll just talk briefly about some other management considerations with our patients with asthma. And smoking cessation, we all know smoking cessation is important for improvement in pulmonary function. The purpose of this presentation is not a smoking cessation focus. So I do just want to point out that use caution with nicotine inhalers or nicotine nasal sprays as they can irritate reactive airway disease. So more preference to other nicotine replacement products or other oral medications. Along with our immunization, so we know an annual influenza is always a good thing for all of our patients. There is some lack of consensus for the support of the pneumonia vaccine, though, for our patients. So in general, we see ACIP recommend PPSV23 pneumococcal for all patients with asthma age 19 to 64, with a recommendation to revaccinate every 10 years. GINA does not report sufficient evidence to recommend that pneumococcal vaccine, so you may see some conflict in the literature. And then again, SNOMED codes for administration of an influenza or administration of a pneumococcal. So again, I want to put this back to ask your opinion. So in what other ways can we supplement the care of our patients with asthma? And do you currently offer dedicated asthma care services? And if yes to either one of these, how can we find some SNOMED codes that best illustrate what we're doing and we can have best documentation? And I'm going to talk here a little bit more about some pharmacist pearls, other things that we may want to consider. First one being our peak flow meters. We'll talk about this in a moment with our asthma action plan, but it's important to be familiar with our peak flow meters. Identifying these are different than spirometers. In our asthma action plans, to use personal best peak expiratory flow as a reference value, and this is a way patients can use an objective level monitoring at home, very much like a glucometer, to see how their asthma is being controlled. Consider long-term daily peak flow monitoring for patients who have moderate or severe persistent asthma, have a history of severe exacerbations, poorly perceive airflow obstruction and worsening asthma. So thinking of that patient that maybe has a very slow decline in their asthma adherence and their asthma control, and so they don't necessarily notice that they're wheezing more, they have more shortness of breath. And for anybody who prefers this monitoring method. And then the long-term daily peak flow monitoring can be helpful to detect early changes in their airway control, evaluate responses to changes in therapy, so to see if a new medication or a dose adjustment is being helpful, and afford a quantitative measure of impairment. Because largely asthma is a subjective disease, so it's hard to maybe keep track, especially if a child is the one who maybe spends some time at school, sometime at a after school activity, sometime with parents in the evening or other guardians. So helping to provide a consistent quantitative measure. Some important parts about peak flow meters is really being comfortable on how to use the meter. So to use a peak flow meter, you would move the red marker to the bottom of the scale. It's important that patients stand up, take a deep breath in, put their mouth on the mouthpiece, and close their mouth around the mouthpiece, and then blow as hard and as fast as you can. So I think it's easiest to describe to patients that it is like trying to blow out one very large candle on a birthday cake. So it's not seeing how long you can force out air. So it's not trying to blow out a whole cake of candles. It's not similar to a cough. It's not seeing how long they can exhale. So it is about as much and as fast as you can blow out. So 1 second. And then their little marker will move into their zone so they can see what zone they're in and use in their asthma action plan. And I'll describe that more in a moment. This is a little bit different than some other pulmonary function tests, so I throw this slide in here just to make sure that we have an awareness of what these numbers are. So spirometry is used more for diagnosis. It uses an FEV1 or forced vital capacity, FVC, and has some specific numbers for where we are going to consider obstruction. So our peak flow monitoring is a patient's measurement against their own personal best. So it's not against a reference value. It's not against our general population. It's against themselves. And that's where we're going to use it for our asthma action plan. And our peak flow system generally operates in our asthma action plan as the red, yellow, and green kind of stoplight mentality. So green is our peak flow, or FEV is 80% or higher of our greatest score, so 80% of expected. Our yellow is 50 to 79, and our red is less than 50. Asthma action plans can be greatly individualized to the patient, but they follow a few main components. So our green zone is like green for go, so no action needed. Continue to monitor breathing and maintain adherence. Our yellow zone is a corrective action zone. So depending on the specific patient, and again, these plans are individualized, Patients may use their SABA, so an inhaler or a nebulizer, and then recheck. Depending on the cause of their movement to the yellow zone, there may be a short course of oral steroids indicated, and they would follow up with their PCP. And then our red zone, which again is less than 50% of expected, is our danger zone and requires immediate action. So we would initiate a quick relief action plan. This may be SABA use up to multiple puffs, so maybe 4 to 8 puffs depending on the patient, plus a reach out to the PCP, plus or minus a presentation to emergency services. And that's most often based on how the patient is feeling and if they can contact their PCP. But this helps to provide a very patient-centered management plan where patients are able to make some adjustments on their own and help to keep patients out of the ER, out of hospitalizations, avoiding those progressions to asthma exacerbations. And so for our asthma action plan, there's again SNOMED codes. So there's a SNOMED for asthma action care planning, planning with a parent, and then there can also be codes based on the referral based on their current PEF value. So referral to a physician, referral to a general practitioner, referral to an emergency clinic, or refer to a member of a primary health care team. So again, this can be maybe you are taking a phone call from a patient and they want to know what they should do. You happen to know they have an asthma action plan. You ask them what their peak flow is. You ask them where that lands. They say, oh, I'm at 40% of expected. You make a referral to the emergency clinic and there's a SNOMED code that associates with that action. So to kind of wrap up here, I think one of the most important parts is do not confuse pickup adherence with actual medication adherence because of that inhaler technique component. So that periodic asthma inhaler technique check-ins, we alluded to it earlier, you can disguise a check-in with asking for a refresher or pointers to share with other patients. And that can be as simple as a, hey, Miss Jones, can I ask you how you use your inhaler? I want to make sure I have a good understanding to share with other patients, but I do not use one myself. So can you maybe describe to me how you use it so that I can make sure I'm using the right terms with new patients? And that's a good way to do just a check-in to see if there's any potential issues. And again, that can be a potentially billable encounter, so assessment of compliance with a medication regimen. And the other important part to note is that asthma management is not stagnant. It needs change over time, both in severity in asthma and ability to properly use inhaler types. So we may see that younger children require medication inhalers that are compatible with spacers. And as the child ages, they may be able to use a dry powder inhaler or soft mist inhaler more appropriately. In the same way we see patients as they get older, they may be properly able to use a dry powder inhaler, but as their disease progresses and they are able to exhibit less inspiratory force, they may need a movement to a different type of inhaler. So making sure that we are continually monitoring our patients' ability to properly use their inhalers in that way. So wrapping up, we can all finish the same. If it isn't documented, we know it didn't happen. So here are some resources for e-care plan documentation. So I provide the first one, the ecareplaninitiative.com. It has references and resources through your own e-care plan vendor, so some specific guidance on whatever platform you're using. And then I also like this other one, snowmedbrowser.com, because oftentimes we may know that what we're doing should have a SNOMED code or a way to document it, but we don't know what that is. And you can browse the SNOMED browser for tons of different types of interventions. Do use some caution that it is an international resource, so not all codes are available or applicable here in the United States, but they are very clearly notated on that browser. And I found lots of things just searching for asthma, pulmonary disease, lots of different things that really kind of got my brain thinking about what I could use as a resource. So I want you to take a moment and think about your turn and final thoughts. So in what ways will you adjust your workflow to incorporate asthma management services? This may be an addition of an asthma check-in at pickup. This may be some implementation or deployment of our asthma control test. So how are you going to incorporate that? And lastly, let's review our post-assessment questions. So which medication below is available in both a dry powder inhaler and a metered dose inhaler? allowing for more personalized patient medication selection. And I'm sure any of us that went through the past couple years with all the formulary changes know that we have that fluticasone, salmeterol, Advair Discus, and Advair HFA that can have some differing delivery mechanisms, so that dry powder inhaler or meter dose inhaler, but do not have the same corresponding doses. So thinking now about which of the following SNOMED codes can be used when counseling a patient with asthma. So I hope by now you can see there's lots of different opportunities, and so we'll be looking at all of the above. In our last post-assessment question, what device is used for a patient with asthma to monitor their lung function as an outpatient? And we only talked about one of these, so our peak flow meter. So our spirometer, we said, is more for diagnostics. Nebulizer, we know, is a way to deliver medication. And we didn't talk about a pulse oximeter, but that would not be used for our asthma patients specifically to monitor their lung function. Here's a few references for you. And then the CE requirements. In order to receive CE for this course, you must complete the survey at the below link by March 13th. So there is the survey for you. I'll leave this up as our final slide so you have a chance to jot down the information. Otherwise, I really thank you for attending this presentation, and I am always happy to answer any questions, so reach out to me at any time.